only 1 in 10 patients actually ends up getting a bed immediately up into the hospital. 90% of them wait in the emerge. It's chaotic, it's busy, you're not seen quickly, and if you are sick enough to get admitted into the hospital, you end up waiting on a gurney, you end up being in a hallway, you end up being not cared in the dignified way that you believed that you would be. One dominant belief that people have about why the emergency rooms are clogged, and it is people are using the emergency room when they shouldn't be. And if they would just go and see their family doctor, or if they would just wait till the next day, they would not, the emergency rooms would be fine.
Those aren't the people that are actually causing the problem in the emergency room. The long wait times, the backlog. In fact, those people can be dealt with very quickly and discharged from the emergency room. It's the patients with the multiple complex problems, usually laid on top of a background of chronic disease, that take a long time to sort out what really is going on, what's really happening. Can they be discharged safely from the emergency room, or do they need to be admitted to be looked after in the hospital?
The volume of these inpatients, these medical inpatients that I'm talking about, these complicated patients who have cancer and dementia at the same time, or they have liver disease, but they live alone and there's no one that can take care of them and they need regular blood work. These people who are complicated medical patients, they're growing. And sort of what this slide says is, when you look at UHN, we're seeing year over year growths of these patients of 20%.
There's something that I've called the double exponential effect. The front end of the baby boom is starting to hit age 65. And that percentage of the population will increase exponentially. So you've got this exponential increase in people over the age of 65, and we're just at the takeoff point. We also know that as soon as you enter the mid-60s, your use of hospital services starts to go up exponentially. So now we're right at the beginning of an exponentially increasing group of people who will use an exponentially increasing amount of hospital services. So if we're concerned about emergency room wait times and overcrowding now, we're just at the very beginning of this double exponential effect. And some people have referred to the aging baby boomers as the silver tsunami. Well, this will be the impact of the silver tsunami on healthcare.
But nobody's changed the system to take care of all these people whose lives are being prolonged. Because they're not just walking around normal, doing their normal things. They get sick, they get ill. They're people in their 50s or 40s who live alone, who were strong and able to care for themselves. Then suddenly now they have cancer and have had complications. When they come to hospital, they need care, and it's hard to get them home because they're going to get sick again. So the system has not accounted for the evolution of treatments, and you get a lot of chronic disease. So this population, because of an aging population and more treatments, is expanding on an exponential line. And there hasn't been the thought to be able to who's going to care for those. So what we see is our numbers going up by 20% a year.
What we've seen from the data is the number of general internists we'll need to look after these complex patients is like this, and the number we're training is like this. The number of cardiologists we'll need is like this, but the number we're training is like this. So there's no rational relationship. This is going to exacerbate the effect of the silver tsunami. Who is going to look after these patients?
Because of our specialty programs, and we have several, for example, our cancer program, neuroscience program, our arthritis program, transplantation, and our cardiac programs, we're taking care of some very ill patients who require care over extended periods in their lifetime, and certainly patients who come back to the hospital over and over again.
The healthcare system is complicated, and often when you try and put in simple things that sound really good on paper, they can have an effect, but you don't see the downside effect of that.
The Ontario government has made it a priority to drive something that they've called the wait time strategy. And it has focused around very specific procedures, orthopedic procedures such as hip replacement, knee replacement, ophthalmologic procedures like cataract surgery, cancer care like chemotherapy, radiation therapy. So doctors and hospitals get paid extra for every one of those procedures they do. They're funded to do the procedure, but they're not actually funded to continue providing care for those patients downstream when they get sick and need admission to the hospital for complications or progressions of their disease or treatment.
Our units are full 100% of the time, 24/7, 365 days of the year. There's actually lots of studies. It's accepted that peak operating capacity is 85% occupancy. We're running at 100% occupancy continually. To be told that you're going to be either waiting and emerge on a stretcher, waiting in a hall somewhere, people don't understand that, and that affects their the satisfaction, but also within general internal medicine, you actually have the best specialists to care for you. So you're not going to get the best care for those patients if they're sitting there waiting and emerge. Our frail elderly sitting on stretchers, there's issues with privacy. The emerge department is an emerge department. It is not an inpatient unit. It isn't set up as that.
Another issue with overcrowding, and has been a very significant issue for patients, is people who are brought in by ambulances, when we're overcrowded and don't have a single bed to put them in, they have to wait on ambulance stretchers. So they wait on the ambulance stretcher without actually definitive primary or physician care. At the same time, the ambulance crew can't pass on the patient to us to care for and get back on the road and look after patients in the community that need to be taken from the community, from their homes, into institutions nearby. So you can imagine their times for delivery of care to the community patient is also hindered when we have overcrowding in the emergency department.
These are patterns that are very clear to people working at the front lines. It's not obvious when you're standing outside the system and what you see is a crowded emergency room. Your first reaction is, what are all these people doing here? Why don't they go somewhere else? But when you're inside the system, you can appreciate what the real problem is.
Why is this such an important issue to us as internists is we're at the eye of the storm. So every day when I go to work and do my job and I go down and see a patient, I see them in the emerge and they've been referred to me. And almost the first thing I have to do when I see that patient is apologize to them. Not because that I didn't come right away or that anything's been wrong, but I'm treating them in a hallway. I don't have the ability to be able to provide them the privacy or the dignity that anybody would want or you would want for your loved one, or the reason why we came in to do this. And so there's an inherent initial apology. I'm sorry that we don't have a bed for you. We need to bring you in the hospital. You're very sick, and it starts with an apology. And I think because as internists we're with the eye of that storm, and it's every single day like that, and you see people being cared for in conditions that are unacceptable. And again, it's not anybody's direct fault, and everybody's trying to do their best in the system, but you see people who are being cared for in an undignified way, who are being palliated on stretchers. So at the end of their life, you're providing that type of care. It's unacceptable. And so when you're at the eye of that storm and you're dealing with that system issues, but you have that personal stake in it, it's very compelling to try and solve that problem. There's no doubt that we're living in a model where there's not an endless amount of money coming into the system. We have to make good decisions. When you don't admit problems properly and address them properly, you waste a lot of money. And that is potentially the downside of not addressing this the right way. It might cost X if we did it properly, but it'll cost 2X if we do it the wrong way. We know that when a patient comes into hospital and we don't have the capacity to care for that patient and we keep them in the emerge, or we actually send them off to a surgical ward somewhere in the hospital and cancel that surgery, it costs far more to take care of that patient than if we had planned for that. We know these people are going to be coming to the emergency. They need the care. So by not funding it properly, you're actually costing more than funding it properly. And the care of that patient isn't as good. And the perception, the patient who's waited on that stretcher is being cared for in the wrong part of the hospital. It's just not good in any way. So by not addressing the problem correctly, it doesn't go away. It becomes more expensive and less quality of care.
Who do you want to look after you? If you have heart disease, you're having a heart attack, you want a cardiologist to look after you. If you've got severe asthma, you want a respirologist to look after you. What happens if you've got diabetes, kidney failure, you've got some congestive heart failure, and you're being admitted to hospital with pneumonia? You know, how are you going to bring together all those specialists? And how are you going to deal with the social isolation that sometimes chronic disease results in? The answer is you need general medicine. That's the group of folks in our system who are used to dealing with those sorts of problems, are capable of doing it, and the kinds of people who we need to pay more attention to.